Next speaker is Dr. Kenneth Fong on speaking on Artisan retropupillary IOL implantation after aphakia.
Thank you very much.
10-year safety and efficacy results.
Thank you very much for the kind invite. I think it's quite an important topic to cover in 8 minutes, and there was a whole 75-minute instruction course on this yesterday. So really, I'm just going to quickly run through the IOL options for aphakia, the iris fixated, my surgical technique, the efficacy data, and the pros and cons of this particular IOL in comparison with the other types of aphakic IOL choices. So the IOL options that you have when you have a patient with no capsule support, I think has been well covered by many other courses, but in summary, you have the ACIOL, sutured scleral fixated IOL, the scleral fixated sutureless IOLs, of which there are many, 4-point sutured across IOL with a Gore-Tex suture. We also have the Artisan iris fixated. Initially, it was anterior. Now it's more popular to be implanted retropupillary and also iris sutured. So when you're doing such cases, you have to consider in your practice what techniques you are comfortable with, consider the learning curve of each particular technique, and what is possible in your actual OT setting. Can you actually get the specific lenses that you want? For example, if you want to do a Yamani technique, can you get the specific IOL with the PDF haptics? You also have to consider whether you can get Gore-Tex or Prolene sutures. If you do the Yamani technique, you need a 27-gauge thin wall needle, low temperature cautery. For the iris fixated lenses, you need the specific forceps and also have availability of those lenses. This lens has been around for many years, and in 1998, it was rebranded as the Aphakia 205Y model with the posterior vaulting feature. So it is widely available worldwide. The A constant, if you are using it retropupillary, is 116.9. It's an overall diameter of 8.5 millimeters with a huge range of diopters, and they've just launched a low myope and a minus myope aphakic lenses as well. They even have a pediatric aphakia range. What are the indications? It's very similar to any of the other indications for the scleral fixated IOLs. Complicated cataract surgery at capsule rupture, eyes without any capsule support after trauma in combination with corneal transplantation, and in many of my patients, they have Marfan syndrome or dislocated lenses from the very beginning from congenital diseases. You can actually position these IOLs in any position. They don't actually have to be horizontally because you can grow them. This is important because in some eyes with trauma, their availability of iris tissue may be limited, so you can actually adjust it to the amount of iris tissue that's available. It's often a common question is that when you fixate these IOLs in the iris, whether or not the pupil can be adequately dilated. And it's important to note that the iris is actually fixated to the non-muscular layer of the pupil, and you can actually get a full dilation of the pupil without affecting the examination of the peripheral fundus. So here you can see a patient with an iris fixated IOL or a well-dilated pupil. How I do it is I often combine it with a 3-port pars plana vitrectomy because these patients often have the lenses already dislocated into the posterior pole. I use a 5.5 superior or corneal or scleral incision, 2 paracenteses at 3 and 9 o'clock. Always remember when you're taking the IOL out from the cartridge, you have to turn it upside down before you insert it into the anterior chamber. You rotate it, I grasp it with the IOL forceps, and I push it down, 1 haptic behind the iris, and I enclavate it with a round cannula. I do not use the needle that they provide because that's more designed for anterior fixation. I repeat with the other end, suture the wound and remove the viscoelastic, and very often I do not do a PI or constrict the pupil. So in the interest of time, I'll just show you a short video. This is a patient with previous blunt trauma to the eye. I've already removed the lens from the posterior pole. I've already done the vitrectomy. I'm in the process of injecting viscoelastic. So here I put in the IOL with the Artisan forceps. The IOL is upside down, so that's very important to note, but you can actually see it vaulting anteriorly. All the time, as you must imagine, you have to control the infusion pressure. With the lens, with the wound open like this, I do not switch on the infusion pressure because everything will just gush out. I put a bit of hydroxymethyl cellulose to improve the view. And you can see the view is much better. You can use any sort of spatula you want to position the lens in a correct position. The paracenteses have been made here at 3 and 9 o'clock, and it's well marked by the bit of blood at the periphery. So the next step is really to grasp the IOL with the forceps, ensure there's adequate viscoelastic in the anterior chamber, obviously protect the corneal endothelium. And you can see here, I insert the 27 gauge round cannula through the paracentesis, and then I put the haptic behind the pupil, and then I just pull up and push down at the same time, and it literally takes half a second. And then we will repeat the same on the other side. So in total, this is a very quick and elegant technique with a very low learning curve that almost all surgeons can manage it. We run wet labs around the world. We have artificial eyes that can simulate this retropupillary implantation, and many doctors manage to do it the first time they try it out. So I repeat the same on the other side. So you can see here, you can insert the round cannula through the other paracentesis, grasp the IOL with the Artisan forceps, enter the iris eye, and just push up on the iris, and then you get perfect enclavation. So you can see that after it's enclavated, I inject the infusion, you can suture the wound, and then the pupil is nice and round, and remove the trocars. So this is a picture 1 week post-op, a nice round pupil, very subtle enclavation of the iris at the tissue. And the tips are that you should avoid hypotony, good feel of viscoelastic. I often do not need to myose the pupil because too small a pupil size will make it hard to push the IOL behind the iris, and remember to use the correct A constant. Here's a range of the many eyes that I've done over the years. You can see there's a range of conditions. They've had traumatic aphakia, they've had peripheral iridectomy, they've had trauma to the pupil, but all of them have well-centered Artisan IOLs with very good visual acuity outcomes. So my personal experience for the last 10 years, I've done about 154 eyes, average follow-up of 5 years, mean post-op visual acuity of 6.9. In terms of the complications, 0.02% will have choroidal effusion or hemorrhage, 0.006% retinal tear. In one patient, which is a very high myope and deep anterior chamber, I was unable to enclavate the intraocular lens, and I had to put an anterior chamber intraocular lens implant. Postoperatively, the endophthalmitis rate was very low. The most common complication was really late haptic dislocation, and then if there's time, I'll show a video of how you can re-enclavate the haptic. High astigmatism in 3 patients, corneal decompensation in 1, glaucoma and cystic macular edema also are very low. This has all been reported worldwide. Follini's group reported 320 eyes over 5 years with similar complication rates. Min Kim in Korea also had 103 eyes with a very similar outcomes, which are very good in terms of follow-up and also visual acuity. In terms of, there was a meta-analysis published comparing scleral fixated versus iris fixated, and they concluded that the implantation of iris fixated IOLs had a more simple learning curve and short compared to scleral fixated IOLs. Interestingly, this paper was meant to promote the use of the Sharioff-Caravale 4-point scleral fixation, and I found this interesting because this table in the paper itself showed that the iris fixated posterior lenses had the lowest complication rates of 2.8% CME, 0.3% vitreous hemorrhage, and 0.7% retinal detachment compared to all the other intraocular lenses. So as we know, conventional IOL fixation techniques have many other complications which I won't go into. There's not enough time. You have the lens-related complications of lens tilt, decentering, suture-related complications such as endophthalmitis and degradation. Refixation and rescue of these IOLs can be invasive, time-consuming, and technically challenging. So I won't show this because my time is up, but you can refer it to online. This is a simple technique of how you can rescue and refixate a partially disenclavated retropupillary iris intraocular lens. So in summary, the retropupillary iris fixated IOLs have a short learning curve and quick surgery, good long-term visual acuity results, low rate of endothelial cell loss. It's obviously not suitable for eyes with no iris tissue, and often you have to combine it with a vitrectomy operation. The surgical technique is easy and fast and has a very good long-term stability and results. Thank you very much.
Any questions?
Can I ask a question?
Yeah, of course.
Kenneth, have you looked at the endothelial cell counts in the 4 quadrants?
4 quadrants?
Yeah, not just central.
No.
Yeah, you'll be surprised that cell count in the periphery is lower than in the center.
Is that because of the manipulation at the time of surgery?
No, I think when the patient moves forward, the whole lens flops forward.
I see, yeah.
And the iris goes against the cornea, and that contributes to what we would call Brown-McLean syndrome. And I've been explanting these IOLs today.
Yeah.
What is the rate of, because the main concern with the Artisan IOL retrofixated is the dislocation or falling the lens back into the vitreous. So what percentage of cases you have come across?
Well, I think in our series it's about 0.05 or less than that. So it's quite small, but I think it's very important that you get proper enclavation of the tissue at the time of the thing. And the thing, okay, the one drawback is it's very hard to remove the lens if it's been properly enclavated. So to disenclavate the lens is extremely difficult, and sometimes you have to pull it, and you have some trauma to the iris tissue. But to lose late dislocation is quite not very common.
Got it.
Thanks. Yeah.
Can I ask
Yes.
one question, sir?
Please, please.
Very nice surgery, sir. I have limited experience. I have used only 10 of these retrofixated IOLs, but one of the patient developed RD. So during discussion, they are telling there should be a prophylactic barrage laser. So do you do regularly for that?
No, I think the main reason they get RD is incomplete vitrectomy. And of course, I mean, I didn't show the video, but at the end of once the lens is implanted, I do a fluid air exchange. I check the peripheral retina to make sure that's all clear. So yeah, it is a bit difficult, I think, but it's similar to if you were doing what any of the other scleral fixated IOLs, you do have to check the peripheral retina.
Thank you very much. Thank you, Dr. Kenneth.